Good afternoon, everybody. Welcome to our free webinar on the health insurance marketplaces and exchanges presented by Alliance Life Sciences. Today, we've got a great presentation for you on preparing for 2015 and beyond. The new marketplace is a window to the U.S. benefit and access evolution, and 2015 will be your doorway to new opportunities and challenges. Today, you're going to hear from Dr. Joel Auerbach, who is the VP of Health Policy and Strategy here at Alliance, and he was formerly Chief Pharmacy Officer for Excellus Health Plans. So he's going to, just a quick rundown of what he's going to discuss. We're going to talk about understanding year one, the results and trends, and what it means for market planning ahead. We'll talk about evaluating the key winners, payers in various 2014 market exchanges, and who's going to be best positioned for 2015. We'll also talk about considering the impact of drug benefit trends and formulary design requirements for your exchange market strategy, and just in general how the marketplace will impact your commercial business ahead. So the only little administrative thing I'll just talk about here real quick is if you have questions, we encourage you to log them on your side panel, in the GoToWebinar side panel that you have on your screen. There's a questions prompt there, and you can just log them as you go, and at the end we will read them out anonymously, and Joel will answer any questions you may have. So with that being said, I am going to pass it over to Joel.
Yes, thank you, Art. Well, welcome everybody. This is the third webinar in a series that we started last year, and it's been quite a journey for those of you who've been with us on these series. Certainly you could attest to that. If we were to basically state in just a series of cartoons a little bit of what that journey is, we're currently in June, and the picture is a whole lot different than it was back in October when open enrollment started. And certainly starting in October, the politicization of the exchanges and what was going on with the Accountable Care Act, or termed Obamacare, was certainly in the headline. It's really continued in the headlines. As we moved into November, it really intensified, and then if you had to sum up the fourth quarter, was this really going to be a catastrophic plan? Well, certainly we know that's not the case, and as we'll see in a minute, the marketplace is alive, and it is well, and it is here to stay. And what we're going to be talking about today is going to give you a rundown of where we are in terms of the numbers, the states, the insurers. We're going to talk about some of our observation and insights of what we've seen in the marketplace relative to benefit design and pharmaceutical benefits, and specifically I'm going to take you on an updated shopping experience. I've done this in the past to some degree, but there's some interesting insight into looking at what a plan offers and how patients and members and individuals are going to be making a determination in the future that is critical, depending oftentimes on specific drugs that they may be taking. And we're going to end up really looking at the marketplace as a window, as Art alluded to insurance and drug coverage transformations ahead. And then looking what can we expect in the 2015, 2016 marketplace, and then what are the implications that we have. Well, the new insurance marketplace, where are we? 8 million strong, and that's the last reported numbers from 4/19. It is expected that that will continue to grow. Even though enrollment is closed, open enrollment is closed, there will still be people who qualify to enroll into the exchanges. So we're not going to expect dramatic growth, but it will certainly increase. 85% of those who are enrolled pick the two lowest actuarial plans, the bronze and the silver, and about 85% who enrolled also receiving financial assistance. For those 8 million people, they're being offered, and they've picked an insurer out of around 275 who are offering qualified health plans in the marketplace. There's about 250 new formularies that are attached to over 3,000 new benefits that are being offered as part of the 2014 marketplace. When we look at the 85% of folks who are getting subsidized, the average will be about $4,000, a little over $4,000, and that will continue to increase each year. And a number that I've used in the past, if we try to anticipate over the next good number of years what the additional drug spend will be because of overall health care reform and the increase in number of people who have a drug benefit, it's been tagged at over $25 billion. Well, if we think about the membership distribution and what 2014 meant, clearly the CBO projection going back a ways had tagged it at about 6 million. It actually dropped from about 7 down to 6 million and certainly exceeded that by 2 million because of the substantial increase in enrollment that we saw in the last month and actually even in the last couple of weeks of that last month, which is not a surprise knowing that there was that deadline. The other aspect of this is what's important is where do we see, this is the starting point and this is likely to increase. What I think is important is with the exchanges we're going to continue to see some pretty substantial increases through 2015 but really escalating and somewhat starting to level out according to the projection by about 2016, which isn't that far away at about 24 million lives. We also see Medicaid expansion, 2014 being about plus 0.7 million already. Tagged about 6 million additional people have signed up for Medicaid. The April numbers are really somewhat enlightening with at least 1 million additional people who are signing up for Medicaid, mostly in those states who've expanded Medicaid, but there's also been increases in the other states, if only because of the awareness that is going on now about what benefits and opportunities people have to gain coverage. So we are going to see Medicaid continue to grow. The latest figures are that there's actually a total of about 65 million people now covered in Medicaid and CHIP, which is 1 out of 20 Americans. Employment-based is something that we'll talk about in a minute. Again, a change in terms of, number one, people who are either losing their coverage or employers who are shifting their coverage as well. That's also part of the dynamic, and already starting to see a drop in the uninsured rate, which is really what this was all about in the first place. Well, if we think about the open enrollment, the marketplace enrollment, where are the top states? We depicting for you on the slide the top 10 states and the actual enrollment as of that April 19th date. See, obviously, California, Florida, and Texas, they actually represent almost 40% of the enrollment. The top 10, about 65%. Many of these were really not a surprise, particularly as we've targeted projected enrollment based off the number of uninsured and potential enrollees in the marketplace. If we look at 2016 numbers, that would be that targeted enrollment as well. So a good starting point in year one. If we begin to look at the top insurers and who have won, and again, based on projected enrollment, it is state enrollment is very we do have actual numbers for it. The individual insurers, it takes a long time for an insurer to actually get a sense of how many people have enrolled. Plus, there's the other aspect of it is that folks do not need to go through the government or the HHS.gov site or to the state exchange site to actually sign up for a plan that can go directly to the insurer. So we're using projected numbers here, but clearly you'll see here that within the top states, a number of plans have done very, very well in the marketplace getting this new membership. And if we think about this from a targeting perspective with over 270 insurers, the top 20 represent about 50% of the enrollment. And we'll talk about more of that when we get into what we can project out for 2015. We think about insurance enrollment modeling and projection, and just because there is a fascination with numbers and also a need to get a sense of who is best positioned in the marketplace, as we and a number of others have done, projected enrollment based on the predominance in the market, based on the premium pricing that they've had in the market, how many regions within their state they were marketing in, etc. So California is one of the states that actually has presented actual enrollment numbers along with the state actual, and we could see that our early projected enrollment and the methodology that we used in California, it turned out to be reasonably accurate in terms of how patients actually decided which insurer they would take. The bottom line here, with a number of different choices in California, the top 4 insurers really picked up over about 94% of the business. What these numbers, again from HHS and some of the CBO projections, what they don't tell us is other information that may suggest that this is still going to be a volatile and potentially a very significant market. So I alluded to the fact that you've got beyond what is reported by the government is that you've got enrollment directly with insurers. Again, those folks who are not getting subsidies, who can sign up directly. Some estimate could be 15 to 20% more folks. You've also got something new that could go on, which is a hybrid Medicaid expansion programs, and there's a number of states, Pennsylvania, Idaho, and I believe Arkansas. We're also looking at using Medicaid funds to subsidize coverage for qualifying individuals, particularly those in that 100 to 138% of the federal poverty level, to actually get into the QHPs. So instead of enrolling in Medicaid, is there an opportunity to help provide assistance to have them get into the normal to the exchanges? And there could be upwards of 6 to 8 million additional people who could qualify, depending on how many states go in that direction. We're also starting to see some interesting analysis of what this all means in the marketplace. And Standard & Poor had an estimate that you could see the S&P 500 companies shifting a lot of their workforce from job-based health coverage to the individual markets that are sold. And this is a transition that may start slowly but ramp up pretty quickly by the end of this decade. And there's a lot of folks who are involved here. And I thought a fascinating statement, and one that came out of the Goldman Sachs report, is because now you're not tied to your employer to have insurance, and particularly for those folks who are perhaps not quite ready to retire but not Medicare eligible, we're finding that there may be an increase in the number of workers who retire or elect to do something different than stay with their current employer, and therefore would present another pool of people who could join the marketplace. So with that, we might expect that there could be more than the 13 million next year, and potentially more than the 25 or 24 million by 2016. When we take a look at the 2014 marketplace, one of the things that we see in the headlines literally every week, but things that we should not be surprised by, are the different benefit designs in the marketplace versus commercial, the higher premiums, particularly in some states versus other coverage, higher medical deductibles, higher copays or coinsurance, more coinsurance design, limited smaller networks, stricter rules, sicker older patients. These are all the things that, when looking back and at the construction of the marketplace and how the ACA has really formulated the rules, regulations, and the game plan and rules that needed to be followed to set it up, this is not a surprise. And what I want to do is I want to show you the reason why this shouldn't be a surprise. Again, trying to frame what you're going to see in the marketplace and what can we see ahead. When we talk about why none of this should be a surprise, it really boils down to actuarial value. And what happens is that there is a new reality in defining what is cost sharing in the marketplace. And why people were shocked, sticker shock, you've seen that as a headline, is that we are now dealing with benefit levels that are covering less of overall Medicare medical cost than they traditionally have. And remember, medical costs continuing to go up. So I've just outlined on this slide 14, and what you're seeing here is what people are really used to. And people are really used to a benefit, an insurance benefit that covers 80% or more of the anticipated medical costs. Some of them have been 90%. 90% is actually the highest platinum level that we see in the exchange, but only 5% of people have selected that. Historical and average employer-sponsored is in that 82 to 85%. The gold level exchange benefits, only 9% have selected that, or 80. But remember, 85% of the folks have selected a silver or bronze, which is in that 60 to 70%. So we are talking about literally anywhere from 10 to as much as 30% of medical cost shifting that is going to gone from somebody else paying for it, i.e. an employer, down to the member. So it shouldn't be really a surprise. Again, we're talking about benefits now that are richer than existed before. So we're talking about adding benefits, the 10 essentials, prescription drug being one of them. You're adding on additional coverage rules due to the Accountable Care Act, such as preventative medicine at no cost. You're putting limits on cost sharing, no annual limits, no lifetime limits. There's also now a cap on out-of-pocket costs, which we'll talk about. And then, of course, the meeting actuarial value basically means that premiums would have to go up to cover more, and again, oftentimes very, very state-specific. Well, we begin to look at some of our the data, and we have captured in our Exchanges 360 program over 2,600 benefits from the 270 insurers and 250 formularies. And what we're finding is that, in fact, we're seeing medical deductibles, pharmacy deductibles, and out-of-pocket maximums that are higher than what has previously existed on the commercial side. And we're giving you a snapshot here, and just to, again, focus on silver, that the average medical deductible, which means this is how much you're going to pay out of pocket before the benefit actually kicks in, is $2,700 for silver, the most common benefit selected, whereas the commercial average overall is about $1,100 going back to 2013. Pharmacy deductibles, well, more on that. That's a smaller number of plans have a specific pharmacy deductible in addition to the medical deductible, and you see what that is. Your out-of-pocket maximum is, again, as part of the regulation, cannot be any more than $66,350 for an individual, twice that for a family. And you can see here, just even for the high deductible health plans that are there that have high deductibles to begin with, it's considerably more. One of the interesting findings in the marketplace, and if I had to define one aspect of the new pharmaceutical benefits in the marketplace, is that this year would be the year of the tier. And what we're seeing in the marketplace is 80% of the benefits have 4 or more tiers, 20% are a 5-tier drug program. And again, as a benchmark, in 2013, we really saw just 23% of workers covered under commercial insurance had 4 or more tiers. So again, no surprise. When we begin to look at how the exchanges were constructed, and particularly the pharmacy programs and formularies in 2014, formularies were by and large really mimicking the commercial formularies. There are differences, and we'll talk about that in just a little bit. But in essence, the formularies would be about the same, but those insurers, particularly those who've had experience in Medicare Part D benefits, where a 4-tier benefit program was pretty standard over the last couple of years, it was a fairly easy transition to introduce a Medicare type of benefit structure into this new type of marketplace. So it is no surprise for those of us who've been in that business or have been observing for a good number of years this type of transition. And again, this is an important component because as we see that plans have had experience with Medicare, you've got a number of new plans in this space that are Medicaid providers. Centene Corporation, for example, who market a lot of the Ambetter programs across a number of states, have been very prolific and successful in creating Medicaid formularies and Medicaid benefits. And those have been introduced to some level, particularly in the bronze level plans. And so what you see people using by their experience creating these kind of benefits to meet the market, this is when we start looking at the exchanges as the window of the future of where we're likely to see commercial benefits going. The next aspect here, what we shouldn't be surprised is specialty drug and the impact that specialty drug has in 2014. And this is going to be an evolving story. It was fascinating that Express Scripts and a much publicized report just looking at 2 months of claims in their assessment, early read, and again this is going back to just basically January and February, they found that there's higher antidepressant, pain medication, seizure medication use, and I would point out that the seizure medication is generally used as part of pain management, if we will. Specialty meds were used to a higher percent of the prescriptions in the new enrolled population, with HIV and cancer being higher. And again, probably not a great surprise if we anticipated that those folks who were sick and had prescription needs would be some of the first to sign up for the exchange. The reality here is that this does not include March, and it does not include the influx of a younger and a likely healthier population. However, this is still an interesting thing for us to keep an eye on, because we would believe that specialty drug use may be what I call a key driver for 2015 premium changes, increases in request for some of the plans. Now, why is that? Because this is the first place that you're going to be able to detect if you have a high cost utilizing member. It takes a long time for bills to come in from hospitals and from physician offices, but what you know is that you're going to see a charge from a specialty drug through the pharmacy program sooner, actually almost instantaneously. So what many of us who've managed Medicare programs used to do, with a quick turnaround of premium, estimating premium for the next year, is that we would use specialty drug and other drug experiences in the first 2 to 3 months, however length of time we had, to estimate what the state of health is in our membership, and then what the projected costs would be. So this is where I will come back and say specialty drug is a particularly critical piece for health plans, and I think something important for our pharma clients. Now, specialty drugs in the marketplace, should there be any surprise, if we look at the benefits in the exchanges compared to commercial benefits, and the EMD Serrano Specialty Digest pointed this out. They actually asked 50 plans who were participating, what are they likely to implement, for 1114, and then for the through the next year. More restriction, having non-covered, especially pharmacy network, limit the care to lowest cost providers, and more restricted infusion network than standard benefits as well, particularly again on the medical benefit infused drugs. So it should be no surprise that this is how this was developed, and this is how it will continue to grow. Let's talk about, again, on the specialty tiers. It's interesting as we've looked at all of these benefits across this. If we think about tiering, we're beginning to see, particularly in the 5-tier benefits, I mentioned that was 20% of the benefits offered, we are seeing preferred specialty and non-preferred specialty drugs now starting to really differentiate themselves. And what you see here is in the copay situation, what the average copay is across or what the copays are for each of the metals offered, the bronze, silver, gold, and platinum, and what the average is within the light blue. So on average, you're looking at a specialty copay of $163, which differentiates itself between $132 as a preferred and over $200 as a non-preferred. If we begin to look outside of just specialty, but in general, and then how are drugs classified as a preferred brand, non-preferred brand, and specialty? When we've assessed literally 1,000, well over 1,000 different benefits on the exchanges, what we have found is a fascinating trend. It should be no great surprise that as one moves from a bronze that covers, again, 60% of the actuarial value of medical care as determined by a pool population, down to platinum, 90%, copays across each of these generally drop. If you see the average on the end here, you can see that on average you're seeing your preferred drug being about 44 and non-preferred about 82. What I have is the benchmark reference, again, from commercial 2013. You're seeing that preferred brand about $29. So again, from 29 in commercial, suddenly it's now up to 44. Non-preferred at 52, now averaging up at $82, and slightly higher, obviously, in the silver and the bronze, and then especially at $80, and that's obviously higher there as well. So you're seeing higher copays across the board, and you're seeing I think a broader differentiation of copays between brand and a preferred brand and non-preferred brand as well. Now we get to the coinsurance part, and I think it's interesting, and my second line on below is coinsurance benefits. We see coinsurance being applied to about 17% of the generic drug coverage, 28% of preferred, 44% non-preferred, and 75% of specialty drug category within the benefits are coinsurance. And this is clearly a higher degree from the benchmarks that I've noted below that. So what you're seeing here is perhaps not as much differentiation, but typically you'll see coinsurance rates as high as 30 to 40% or more across the benefits, with more coinsurance predominance as you move up from preferred to non-preferred, and certainly in the specialty tier. And what I wanted to point out, I'm going to move into the next section, and I'm going to talk a little bit about the shopping experience. And for those who've joined us in previous seminars, I believe I've used this the last time, but we've expanded it to make a couple of points. But this is a California family. Basically was self-employed, making $50,000 a year, and needed to find insurance on the exchange. Just in terms of their medicine cabinet, just to give you a sense of what they have some pretty standard things. You know, Bob has kind of your typical drug profile for a 50-year-old male with some underlying conditions. Janet, not pretty similar, but I think what really I'm pointing out here is the specialty drug for arthritis, which we've brought in at a cost of about $2,500 a month, or about $30,000 a year. They had drug coverage previously. They used copay cards, were available to help reduce their out-of-pocket costs. But now they have to go shopping for insurance. Well, they're in California, and they've got a number of different, and they're in Los Angeles area, so they have a number of different insurers. Many of these insurers who are offering qualified health plans in California. And so when they go and look on the website, it becomes pretty transparent, and you can begin to see the insurers in their particular market and what the premium cost is going to be at each of the different metal levels for this particular family. Well, when putting in his annual salary of $50,000, it immediately comes back and says that the Smith family can get $467 a month in subsidy. And so you see what that does to the premium in that top for the bronze. It will take a $561 premium down to $94. Or under a silver, the $697 a month down to $230, and so forth. So the green is the premium after the subsidy is applied. The note is that the two kids actually qualify for Medicaid and would have coverage under the Medicaid program, Medi-Cal program in California, so a different set of coverage rules. But this is, when you begin to look, what are the coverage differences? And so what we've done is we've mapped out, how much premium are they going to pay each month as you begin to move up to up the metal levels. And you can see it's in this particular case, and it's just coincidental. It happens to be about $100 more per month as you move up to each metal. If you try this at home in your own state, it may not quite work out that way. But because benefits have been prescribed as essential health benefits, although they do vary from state to state. Where health plans can create differences to meet the actuarial model is that they have to shift the cost, and they do that oftentimes by the deductible itself, as well as some of the co-pays for offices. And so I show you that here on slide 26, where you have the maximum out-of-pocket. Again, it's two people. It may vary. A silver enhanced, because of the $50,000, the Smith family actually got an enhanced benefit, and this is part of not only the premium assistance, but now you've got your benefit or your subsidy to help offset other costs that are involved. And typically they are costs that are involved in basically reducing your maximum out-of-pocket cost before the benefit picks up 100%. So I just wanted to point that out. And again, silver enhanced is probably about a 73% in this case benefit. At any rate, the drug benefit. California has a pretty limited choice or options for what health plans can do in terms of their offering. A number of states have been pretty prescribed in terms of no more than 4 tiers or number of tiers, and oftentimes the dollar value is limited as well. But you see what the differences are here. What's interesting under the specialties, it can range anywhere from 30 down to 10% depending on this. Okay, so the Smith family, it's time for some math, and so they're going to sit and they're going to make a determination of what's the best policy for them. But they figure that, okay, we can figure out how much our premium is going to be, but they also figure out that with the drugs they're on, particularly that specialty drug and the physician visits and a lot of unknowns, that they'll likely exceed their out-of-pocket maximum. So when they go through this, they'll read the bronze plan and figure out they have to pay a hefty monthly amount until they get through their deductible, which is $10,000, and then a short distance to hit their out-of-pocket max. And so in essence, they have a fair amount of cash flow that needs to go to cover the drug. And then again, under the bronze plan, it's 30% specialty coinsurance that needs to be that they'll be hit with. So at any rate, they'll figure out that their premium and out-of-pocket, they're about $13,800. When they look at the silver, again, they have cost-sharing assistance that lowers their out-of-pocket to $10,400, and their deductible is also lower. It's $3,000, not $10,000. And by the way, you really are only getting your cost-sharing assistance on a silver plan. You cannot get it on bronze, and you can't get it on gold. So here, what you're going to see is that they'll likely cross over their deductible within about 2 months, get 20% coinsurance on the specialty drug, and then take another 8 to 10 months to hit the out-of-pocket, total about $13,100. What about the gold plan? Well, there's no deductible. Okay. And their out-of-pocket is back at that higher amount of $12,700. But their monthly drug out-of-pocket is really lower, about $700 a month. So the total for the year at that point is going to, because of the benefits that they have, will be about $8,400. And I think what's interesting is when you begin to look at the platinum plan, not only do you not have a deductible, but your out-of-pocket is lower. And then you really have probably your lowest monthly drug out-of-pocket. At that point, your total is about $9,076. So even though folks have gravitated toward the low premium plan, what I believe we're starting to see now is an appreciation that it's more than just the premium. There's a lot of other components to it. And there's a lot of other questions that need to be asked. And therefore, for example, our doctors and local hospitals that we use in the network, a lot of plans do limit that. Although it's interesting, most recently it's been reported that a lot of the California plans, they excluded a variety of provider networks, a lot of the key teaching institutions. I raised the question that if your specialist isn't on the list, how are you going to get your specialty drug? And so this could be a particularly interesting issue. We're seeing now that many of the provider groups and hospitals are beginning to sign on to the networks, and I believe 2014, even though we also refer to this as perhaps a year of reduced network consolidation, we're going to start seeing the networks probably rebound and become a more significant part of the exchanges. It was, I think, a timing issue last year, just simply not enough time to really get everybody on board with regards to the realities of the market, realities of the reimbursement rates. You know, quite frankly, I think in California, when you think about somebody like an Anthem of California who's going after a contract, they're obviously a big player. Well, they now have 425,000 lives within the exchanges. That's a slightly different negotiating position than the unknown that existed before that. Are the drugs we take covered by the plan? You know, it's interesting because if you're not on formula, or if you get out of the network, or you don't go through prior authorization, it's not covered. It may not count. It likely is not even going to count towards your total out-of-pocket. And there are actually a number of plans that have built in a whole separate structure for out-of-network coverage, which can be tens of thousands of dollars of out-of-pocket liability. So this becomes important that if you don't follow the rules, it can have some pretty decent consequences. Other questions that the Smith family is asking, are copay cards still available for the medication we take? And this has been a very interesting discussion that we've all had over the last year. Some companies have taken a very cautious approach to extending subsidies in the marketplace. Others are providing it. And I would just throw out, will providers and specialty pharmacies, particularly when we talk about the fact that a specialty pharmacy required network is typically going to be the way that these drugs will be obtained, will actually products be recommended based on subsidies and offset to members and to physicians? And so is this become now a more than just improving access through reducing the financial burden of a member, but is this now going to be a critical part of the value proposition with vendors? And do I need to change pharmacies to get my coverage? I think we had mentioned this. Limited pharmacy network is also, a retail network is also starting to play a role. And we shouldn't forget that mail order still has, in many cases, an advantage where it's 3 months for 2 copays, something very similar to what most of you are familiar with on the commercial side. And then what's my best cash flow option? So I think what you're seeing here is that based solely on having a specialty drug that costs several $1,000s a month, the old way of thinking of choice, what we all started with, is everyone's going to choose bronze or platinum, everyone's going to go for the low premium. I think we're going to see a relook, and I think we're going to see suggestion and direction that people evaluate gold and platinum plans as the more likely option. Even though it's higher premium, it may in fact be the best option for a particular patient. And I'll just point out for you here, this is a little bit older data, but one that I had that actually showed by different states how the metals broke out. As I said, the total U.S. is off. That's not updated to the April. But you can see that there's quite a range. When you look at for example, Arizona, where you're finding a 19% gold and 18% platinum, you know, that's a much higher number of richer benefits than we would have expected. And also, when you look at federal, you know, subsidy with assistance, again, you're talking about the silver and the bronze, which makes perfect sense. Without financial assistance, then you're not as relegated and don't have as much benefit of getting silver. And this is where you see literally 40% of the gold or platinum. I think my only caution and concern as I look at 2015, 2016, if everybody with high costs ends up in those categories, the premium on those will just continue to escalate and may become unaffordable. I want to move into, if I can, is my drug covered? And that's, I think, an important question that the Smiths asked, that everybody asks, that there is going to be some state benchmark formulary variability. It will happen because of the regulation that health exchanges must provide the greater of at least one drug in every USP category, or the number of prescription drugs in each category class, as the Essential Health Benefit EHB benchmark plan. Now, recognizing that 70% of the Essential Health benchmark plans around the country that were selected were actually Blue Cross Blue Shield small group plans, and therefore pretty open formularies, we're going to see that this may not be quite as dramatic a change as one would expect. However, there are states and there are differences within states of how many drugs in categories are on the benchmark plan. And I show you an example of them here. And again, it can range from fairly small single digits to larger, much larger numbers as well. So that is going to play a role. I will tell you that in 2015, the rules covering 2014 extend to 2015. There really has not been a change in that. We're waiting, and we'll have guidance coming up likely in the first quarter or so of 2015 about whether or not the benchmark rules will change, be enforced, or what the standard is going to be coming up for 2016. So a question, you know, based on this that we've looked at, does the essential health benefit requirement present an opportunity or a challenge for specific drugs? So when we look at, I picked 3 different drugs here, and then we look at the maximum number of drugs in the class that are to pick. You could begin to stratify states according to their benchmark plan and what's the maximum number of drugs in that class that need to be on formulary. And what you're seeing here is the red states typically have benchmark that require less than the maximum number. We call that a risk only because a drug may not have to be included. The green states, basically, you're going to have to include all of the drugs that are the maximum, literally the maximum number that are in that particular category, which is a potential opportunity as well. So this is one way of beginning to look, but it can be dramatic in some drug classes, and certainly when you'll see in one of my final slides where the challenge will be on new drugs is how does that new drug fit into an existing category? Is it now and how will plans view this if they've already qualified with the maximum number of drugs that they need to have? The other way to look at this is we begin to look at, depending on the formulary, then how is a drug positioned. So we've taken one cholesterol brand and just stratify according to the benefits in terms of not covered or non-formulary, preferred, non-preferred, and see, again, a range of different numbers, oftentimes tied into what's going on with the benchmark numbers in that particular state. Although we're one way that we've suggested that people look at this is that within each state there are going to be winners and there are going to be losers. And this is an example of Colorado. When we look at projected enrollment over the number of different organizations that are offering plans, one can see that there's literally about 3 of the plans that Colorado Health Co-op Humana and Kaiser that are likely to get the vast majority of membership in that state. And then we begin to isolate there is then how are these organizations classifying and what's the access potential for a drug in these particular states. I should probably point out, I didn't before, the co-op. Co-ops are interesting. There's like 24 different co-ops that really were developed to be on the marketplace. And so these are new, these folks didn't exist before, they're new insurers. Some of them are going to be very successful in the states that they are in. Some are going to be challenged a bit, and I say successful because they came out with a very low premium. That may be because they just didn't have experience in the particular marketplace. At this point, it looks like about 400,000 people out of the 8 million have elected to join one of the co-ops, and some of the more successful co-ops are really looking ahead to see how can they expand into some of the other states. My final comment on formulary access and marketplace is taking then the projected enrollment and then being able to estimate, being able to say where is a drug fit relative to that access as being covered, preferred, not preferred, and actually coming up with a number of lives that are fit into each of those categories for the particular drug that you want. And again, that's some of the work that we've done with our formulary access modeling. So if I look ahead as we begin to get here is the window to the future, both in terms of where we're going to see other benefits heading and what we'll see in the year or two ahead. There's new marketplace regulation and guidance potential. It actually came out after I created the slide. Clearly, the CMS's focus for 2015 certification is going to be, are they meeting the EHB requirements? They've just come up with a new tool and provided it to health plans for submitting their drug lists. That is taking place now. Plans can evaluate whether or not they are meeting their formularies for 2015 are meeting that list. And as you'll point out later, or down on the slide here, a lot of activity taking place now because there's literally only 2 more weeks, 2+ weeks, 3 weeks before a plan has the deadline to file with CMS that they are going to be want to be considered for 2015. The other thing is regulation is there's quite a bit of looking now at the use of step therapy and prior auth, particularly for key states like HIV, cancer, and mental health. And again, part of this, there was a fair amount of press about the HIV drugs and who's covering and not covering and whether or not access was unduly limited. So there's going to be some additional looking at this and some guidance on this. We have not seen anything specific as yet. Transition supplies, that's something that's regulated in the Medicare side. It will not move forward at least for 2015. But is an exception process for non-covered, non-formulary drug. They've now instituted a recommendation for turnaround time requirements, which is pretty standard actually for most commercial and certainly for Medicare business as well. And there's going to be looking at formulary tier amounts and member share amounts, particularly for specialty drugs. This is all getting kind of this fresh look. As the market begins to settle out and then begins to move ahead, will there be additional guidance and criteria put in place that insurers will have to work with in order to get to market a plan? The other thing that we're going to see next year is the start of the quality rating system, or NQS. It actually starts in 2016, but there's typically the year before is when insurers have to provide information or data. There will be, not unlike NCQA, not unlike star rating on the Medicare side. There will be about 40 different metrics that insurers will need to report on, and then there will be a rating for the marketplace exchanges starting in 2016. I already mentioned that we are expecting guidance as to what happens with the whole benchmark EHB number of drugs for 2016. So it will be interesting to see. Expect that as we migrate into 2016, additional change there. Membership. As I mentioned early on in the lecture, this could really grow. I mean, back last fall, there were a lot of us who were saying maybe we'll get 2 million members. We're not sure if this thing is going to work. And now we're just, I think we're at the other end. We're not sure how far up that membership could go. Quite frankly, as this becomes a 25 million a member or higher, maybe 30 million, could be 40 million, this becomes a significant portion of the business. And I think that in and of itself is an important, strategically important, that one begin to pay attention to this as well. We've got insurers who are now deciding whether they're going to enter the market, others expanding. Interestingly enough, I see Harvard Pilgrim Healthcare looking to expand to New Hampshire and Maine in 2015, Connecticut in 2016. United, which was very cautious the first year, is one of 4 new insurers applying to have benefits in the Washington state. So these are the kind of things that are taking place that will shape, will sort out and certainly be a significant part of the 2015 issue. And plans are trying to figure it all out. Quite honestly, they're assessing the new population. What about disease? What about risk? Were we able to get healthy people in the beginning in order to help minimize that risk? Let's evaluate our drug use and use that as a proxy for how we can estimate how we're doing and what 2015 is looking like. Premiums are now being submitted and set. We are seeing the first early indications. Some of the, for example, in Maryland, Care First, which is a predominant insurer, requesting a 20 to 30% rate increase. You're seeing Anthem in California, about a 12% rate increase. All of this is going to get quite a bit of press, obviously, and you've got some of the insurers that are looking for a rate decrease. Some of that, I think, is just people didn't know how to get into the 2014 market. Some underpriced it. Some probably priced too high and didn't get any membership. I'm impressed when I look at those folks who are talking about lowering their premium. They weren't projected to get much in the way of any membership at all. So it's really time to think about, if you're going to play in this space, where do I need to be? And I think from a plan perspective, important, reducing and managing risk. How are you going to do this? And even though formularies didn't really change a whole lot aside from the tweak to become compliant with EHB were needed. And we saw, this being the year of the tier and benefit designs, I think we're going to see formularies and network become a stronger component in differentiation. Well, we have different formularies and different formulary rules tied to different metal tiers. So more to come on that, but these are some of the things that we might project. But importantly, just as we saw Medicare help shape some of the marketplace benefits, how is all this going to affect commercial business? First is, I think, transparency. And one of the big issues that we'll see is employer-based insurance for those who will continue to want to offer insurance are going to see that they're, you can go get a rate for insurance that at on an individual market, and then take a look at what you're being charged and go, wait a minute, why am I paying this? And so you're going to see a lot of downward pressure on premium for the employers, and at the same time, there's an acceptability of this whole narrow network thing. This really started before 2014 in the exchanges. And actually most patients, most people who sign up don't have a problem with it. They actually, they like it. Or at least it doesn't impact them. Stricter formularies, increasing use management, it obviously is working in the marketplace. It will transition to employer groups. And deductibles clearly are racing to the ceiling. They're going to continue to go up as a way of meeting the need, and particularly when you've got the Cadillac tax hitting in 2018, where a fair amount of employer-sponsored plans, if they don't do something to really dramatically change their offering, they're going to get hit with a tax that's surely something they're not going to want to pay. It's up to 40%, so they're going to try to avoid that. Private exchanges are, we're seeing that as a transformation from employer-sponsored health to defined contribution. It is estimated that on the private exchange, they could get up to 30 million people or more choosing health plans through the private, not public, but private exchange. So now all of a sudden you've got this whole individual market that's really taken off. And specialty drug utilization and management will be key. It'll help define risk. It's going to be likely accelerate the employer benefit changes. It likely is it's already started to become part of the public discussion if we just think about hepatitis C. So the implications for the pharmaceutical industry, similar to before, we got more people who are insured, but the benefits are different. There's variability in coverage. This is a changing dynamic market. You've got account and care managers out there who need to be on top of this stuff and need to have access to information to understand what kind of relationships, how they need to approach their accounts. It's an integrated approach, medical and pharmacy being managed together, and there will be aggressive competing price demands on existing and new product. And at the end of the day, it's drug positioning. The plans need to add your drug. And this will continue, a question that will continue over the next year. Is there an opportunity for repositioning, and is contracting the way to go? Particularly when you're seeing the benefit change, is it tier positioning, out of pocket, and all the rest, and again, needs to understand how much you're giving up in contracting versus what are you likely to gain from the access standpoint. Same thing with on the formulary side. So new drugs, negotiations, benefit designs, contracting are all things that will continue to evolve and need some really strategic thought in the years ahead. All of that and the data that a lot of the data that I provided are information that we are gleaned from a product we've introduced, the Exchanges 360, which really will pull all this together in both on a web application accessible by iPad, etc., that not only provides state-by-state information, but formulary information and positioning, both in terms of detail, and it's downloadable through Excel, etc. And as part of our broader product, it's not only the web data services, but also all the other support, education, and training and consultation that's there. And we would invite you to simply go on to Health Exchange 360 as this, and you can see for yourself, take a quick tour and to see, and we'd love to be able to hear from you if this is something that you or your colleagues in the organization would like to look at. So the final slide, as we look ahead, 2015 is going to be continued growth and evolution. We are going to see commercial business really begin to evolve and accelerate changes to what you're seeing on the marketplace. This is truly a window. Having somebody who's done this for almost 40 years, this is tracking just like when we first got into even creating pharmacy benefits. Access challenges and opportunities will continue to evolve, and I'm expecting a very loud and elevated discussion on specialty drug. And with that, I know I've probably taken you right almost to the end here, but if there's been questions, let me turn it over to that, and more than happy to stay on if we needed to help address those.
Thank you, Joel. So we are right here at the end of the hour. We actually, so kind of funny, so we don't have any questions, but we do have quite a few compliments, Joel. Apparently everyone really liked your presentation.
Well, I'm more than happy. I like questions as much as compliments, so please feel free to get back to us if you do have a question.
Yeah, absolutely. So we'll wrap it up here since we are at the end of the hour. If anyone has any questions, please feel free to reach out to us. You can reply to your webinar invite, and that'll come straight to us. And other than that, thank you, Joel. Great presentation, and everyone have a great rest of the afternoon.
Okay, thanks.